So, second presentation, same agenda, new devices, new techniques, but this time in unruptured case scenarios. I'm not gonna lie, we do all know that dealing with ruptured cases is like fighting a Godzilla, so we all prefer to avoid dealing with SAHs and acutely ruptured aneurysms if we can, of course. When it comes to the management of unruptured cerebral aneurysms, you can start to be a little bit more creative, use a lot of new technologies, find your patients, put the patient on double antiplatelets, prepare him for stent or something like that, or the new sophisticated devices like the Nautilus. In our department, we do have experience with the all those for recently introduced stents. That's the second generation Elvis stent, recently introduced intrasaccular implant called Nautilus. I think we perform all the 30 first-in-human cases in our center. The well-known Atlas stent and the new fascinating P64 with the HPC technology. So a lot of options available. I'm going to show you a bunch of cases we did with the all the aforementioned devices. This is a ruptured symptomatic MCA aneurysm with a really complex anatomy. The plan here was to deploy permanent stent that Elvis Evo from M2 to M1 and sufficiently embolize the aneurysm. The stent is a second generation, has a lot of improvements in terms of like better navigability, visibility, and the new improved delivery system. You can see the implant over there on the furrow. With the scaffold across the aneurysm neck, we managed to achieve like a sufficient degree of occlusion of this complex MCA aneurysm. And the second case is a very representative case of Nautilus embolization. That's a symptomatic 60-year-old lady with a prominent visual deficit. We found a giant internal carotid artery aneurysm, and we decided we should go for stage embolization. Due to the complex anatomy in the relatively wide neck, we decided to implant that sophisticated device inside the aneurysm. A bunch of words about the Nautilus device. It is made of a nitinol alloy, and the first few loops actually behave like a coil when they're inserted into the aneurysm. The device has some sort of a temperature or memory-like shape. Once it gets fully introduced into the aneurysm sac next to the equatorial plane of the aneurysm, it forms like a discus shape thing, which can be deployed at the level of the neck and help you to completely remodel the aneurysm. It has a central pores over here, central pore, that you can use a second microcatheter and navigate through and start deploying coils. So you achieve good occlusion rates. That's a second example of Nautilus embolization, symptomatic MCA aneurysm. We evaluated the anatomy, and we decided that it's very crucial for the patient to protect the bifurcation of the MCA. This is what we exactly did. We deployed the Nautilus device inside the equatorial plane of the aneurysm, slowly retracted the device, navigated through the central pore with a second microcatheter, and started to insert coils slowly. This is the fine angio, and it shows the complete patency of the MCA proximally and distally. Another challenging case, in my honest opinion, that's a MCA kind of ugly aneurysm located at the level of trifurcation. What we did here is, I'm not gonna lie, we failed like miserably 2 times to embolize this aneurysm with like the simple coiling or the assisted coiling with balloons or whatever. So we thought that it's a good idea to do Atlas in Y configuration. That's exactly what we did. So we navigated into the inferior branch and then up to the superior branch. And we deployed 2 Atlas stents into the Y fashion. That's the vaso-CT reconstruction, and you can see the patency and the full reconstruction of the MCA trifurcation. That stable configuration of the stents actually allows us to deploy a bunch of coils inside the sac and therefore prevent the aneurysm from future rupture. These are the following images, the insertion of the coil mass, and that's the final result. Another tricky aneurysm, actually this aneurysm is unruptured, but it showed progress on the follow-up. It started to increase diameter, so we thought it's a good idea to propose a treatment to the patient. In such cases, when you have like a broad neck or the very, very small sac, we prefer to deploy a stent. That's the P64 over there, completely deployed across the aneurysm from proximal A2 to distal A1 across the ACOM complex. That's the VASO-CT reconstruction. You can see a perfect tubular shape implant that covers the aneurysm over there. And another case example of flow diversion in small vessels. As far as I remember, this patient was actually consulted and she was offered no help, no treatment because, I open quotes, there are no such device for distal anatomies. However, we successfully managed to navigate through the ACA and we deployed 3x15 P48 stent across the aneurysm neck. You can see the perfect deployment of the stent across the ACA and the aneurysm neck. And over there, that's the final result. No damage to the vascular of the territory of the ACA. Sorry. And that over there is a really good predictor of aneurysm occlusion after flow diversion. You can see that's the stasis of the aneurysm sac at the late venous phase of the DSA. So I'm going to conclude the same as from my previous presentation. Coiling is really, really a good option, but sometimes you have to consider a lot more opportunities if you have the chance in the armamentarium, of course. Thank you very much.
Very nice talk, thank you. Is there some questions rising from the audience?
I would have one. So those were some really challenging cases, so really congratulations on how you managed them. I've got one question that is, especially in the mucotic or larger aneurysms, of course, if you use the Comanche, for example, you will not have the possibility of a balloon there. If there was a rupture, when you have a balloon, you could use the balloon to stop any bleeding. Do you sometimes use an additional balloon, probably also via the other groin, in those tricky, where you look at them and they already look as if they're very likely to rupture?
Well, we do acknowledge the fact that actually that's the only disadvantage of the temporary stent devices because they're not occlusive. So in case of interprocedural rupture, either it's a parent vessel or aneurysm, you're helpless. So you got to puncture the groin, navigate, and hopefully get into the rupture point and deploy the balloon. That's the only reason why we never actually performed that much double Comanche or double stenting. We want to have at least one occlusive device deployed into the cerebral vasculature just in case something happens. Not gonna lie, we've seen this. And thanks to God, we had our balloon next to the parent vessel, so we could stop the bleeding. But yeah, when it comes to like mycotic aneurysms, we have like a limited experience. I'm not gonna lie, like 15-ish cases or something like that. The very last one was recent. But what we do in mycotic aneurysms, we try to avoid using sophisticated approaches like assisted coiling or something like that. All we want to do is like deploy 1-2 very firm, very tiny coils or add some liquid embolic agent, and that's it. Go away.
Fantastic. And another thing, you were showing those excellent reconstructions. So what is your recommendation? Do you also use flat panel imaging where you can see the actual struts? It's probably really something you could tell the audience.
Our protocol was before the era of Bulgarian antiplatelet testing. We recently started to test our patients like 3-4 years ago, something like that. And we had that protocol that we waited like 15 minutes after deploying any device into cerebral vasculature just to observe any acute stent stenosis, thrombosis, or something like that. Nowadays, with the new machine that was installed in our department, we have the opportunity to do flat scans and VASO-CTs and better evaluate the patency of the flow diverter or whatever it's inside the vessel.
We use that for our follow-up as well.
Yeah.
now.
No, actually, no.
They
We do
use
this
MR?
as only
Okay.
MR.
Yes.
Those.
We do control angels, and if we need it, the second follow-up, we are going to MRI.
Yes, so we do the same, but if there's any question, if there's something with the struts or if there's stenosis, then it has, what I wanted to point out is the amazing image quality that you can
really?
achieve
Yeah.
with flat panel, which you cannot get with CT.
Nowadays,
So,
we don't wait for the 15 minutes control. We just do the VASO-CT, and you can see the patency of the
Yes.
vessel. It's pretty accurate and in high detail. So,
Thank you very much.
Oh,
Thank
pleasure.
you. Thank you.
Thank you. So we are going